Next session will be HBV3 functional cure of CHB in real world, chaired by Zia Honkao, Taiwan, Osamu Yokosuka, Japan, discussant Yasunari Nakamoto, Japan, symposist Motoyuki Otsuka, Japan, Railway, China, Chenin, China. Thank you very much, the lecturers and moderators.
Okay, good afternoon, everyone, dear colleagues, members, and ladies and gentlemen. I'm Dr. Jia Honggao from National Taiwan University, Taipei, Taiwan, and my co-chair is Professor Yokosuka from Chiba University, Japan. So I think in this section, we are talking about a very important question or a main need, that is the HBV functional cure of chronic hepatitis B in the real world. So as we know, the HBV infection is very rampant in the world, and more than 70% of HBV carriers are residing in the Asia-Pacific regions. So in the Asia-Pacific countries, the patient with chronic hepatitis B will progress to liver cirrhosis and hepatocellular carcinoma. And the functional cure is one of the hope they can convert to the favorable clinical outcome. So how to reach the functional cure? That is zero occurrence of HBs antigen is very important. However, by using current therapy, including interferon and nukes, the rate of S antigen loss is very low. Therefore, we need new drugs or new strategy to reach this very important goal. So that's the reason why we are here to discuss the functional cure of chronic hepatitis B, and we invite three distinguished speakers to touch on different issues, and also we have a discussant, Professor Nakamoto, in these sections. So without further ado, I would like to introduce the first speakers, Professor Motoyuki Otsuka, to the podium. And he will give a talk about advancing towards the functional cure of HBV. Professor Otsuka, please.
Yeah. Thank you very much for your kind introduction, Professor Kao. And I'd like to thank Dr. Shina and Dr. Omata for giving me this opportunity. First of all, I'm not sure if my talk matches the topic of this session, but anyway, I'd like to talk about our recent results advancing towards functional cure of HBV. Nothing to disclose. So before talking about the results of our study, I'd like to share about the current status of chronic HBV infection in Japan. These are the changes of the etiologies of liver cirrhosis in Japan. As you can see, the primary cause of liver cirrhosis has shifted from HCV to non-B, non-C. However, HBV still accounts for 9% cases of liver cirrhosis in Japan. And this frequency does not change recently. So this is a famous study by Dr. Tateishi about the background etiologies of hepatocellular carcinoma. As you can see, the HCV cases are dramatically decreasing recently. Instead, non-B, non-C cases is increasing about HCC. About the etiologies of HCC. However, again, HBV cases remain at about 10% of the HCC cases in Japan, and this frequency does not change recently. So under these situations, what is the goal of HBV anti-HBV therapy? So according to the guidelines published by the Japan Society of Hepatology, the long-term goal of antiviral therapy is defined as HBs antigen cell clearance. Of course, this is just a surrogate marker, but currently, HBs antigen clearance is defined as the goal of antiviral therapy. This is because, as you know, HBs antigen cell clearance is closely related with reducing the risk of HCC, as shown here. And HBs antigen cell clearance contributes to the better prognosis of HBV patients. However, as you know, by the nucleoside analogs currently used, HBs antigen cell clearance is rarely achieved, or it takes a long time to achieve it. So then we need to develop new antivirals to achieve HBs antigen cell clearance. Last year, a review article about new approaches to chronic hepatitis B was published in New England Journal of Medicine. According to this report, there are many multiple steps which can be picked up for the target as a target for the development of new antiviral therapy. In fact, many compounds are under development as new antiviral therapy against HBV with various mode of actions, such as entry inhibitors, the translation inhibition or RNA decay, capsid inhibitors, innate immune activation, and so on. Among these, the phase 2B result of bepirovirsen was reported 2 years ago by Professor Yuan. Bepirovirsen is a modified antisense nucleic acid, and it targets all HBV RNAs and at the same time activates toll-like receptor 8 related pathway. So in this report, patients were divided into 4 groups with different doses of bepirovirsen. And among them, the most responsive groups showed HBs cell clearance at about 9% of the cases. So 9%, this is a promising result, but still, in the most responsive cases, only 9% showed the HBs clearance. Then we need to continue to develop new antivirals to achieve HBs antigen cell clearance. Then we focused on SMC56 protein complex, which normally inhibits HBV RNA transcription. So this is a principle. SMC56 protein complex normally blocks HBV RNA transcription from cccDNA. However, once HBX protein binds with host protein DDB1, this protein complex triggers the degradation of SMC56 protein, then leading to the start of HBV RNA transcription. If this is the case, inhibitors of HBX protein and DDB1 protein binding may inhibit the degradation of SMC56 protein complex. And then SMC56 protein complex is restored and blocks HBV RNA transcription, leading to HBV protein reduction. After searching for such a compound, we found one candidate such a drug, nitazoxanide. Nitazoxanide is an antibiotic which is already approved by FDA for some pathogens. We found that this may inhibit the binding between HBX protein and DDBM protein, and then then inhibit the degradation of SMC56 protein complex. So this result was featured in the editorial of CMGH in 2018. And based on this result, so the principal HBX protein and DD1 protein binding inhibitors inhibits the degradation of SMC56 protein degradation. And then SMC56 protein complex restored, and this complex blocks the viral RNA production, and leading to the viral protein, including SBS antigen reduction. So this result, based on this result, result of a pilot clinical trial using nitazoxanide to HBV patients was reported in 2019. In this report, 3 out of 9 cases showed HBs antigen seroclearance at 24 weeks after the initiation of nitazoxanide administration. That means 3 out of 9 cases, about 33% achieved disappearance of HBs antigen in sera. So based on this result, phase 2 clinical study has been is underway from September 2019. In this clinical trial, nitazoxanide is used to the patients with E antigen negative chronic hepatitis B. So in this trial, patients are divided into 4 groups with different doses of nitazoxanide. And the primary outcome is the seroclearance of HBs antigen at 12 weeks after the initiation of the nitazoxanide. This is an add-on study, so the patients continue to use nucleoside analogs, and nitazoxanide is added to them. Also, the study is still underway, but a review article published last year from China described that nitazoxanide may be one of the most promising agents to clear HBV infection. So, in addition, nitazoxanide decreases the cccDNA levels as well. This is theoretically, nitazoxanide inhibits only HBV RNA transcription levels, but probably because HBV proteins stabilize cccDNA. Then once nitazoxanide inhibits the HBV protein levels, cccDNA also cccDNA is destabilized and decrease in its level. So this means inhibition of HBV RNA expression reduces viral RNA and viral proteins, but at the same time, it may lead to a decrease in cccDNA levels as well. So if so, we may be able to eradicate HBV we may be able to eradicate HBV completely, including cccDNA. So this conclusion, HBs antigen clearance is crucial in chronic HBV infection. Inhibition of HBV RNA transcription is one of the options to achieve such a goal. Thank you very much for your attention.
Thank you very much for the very nice presentation, a comprehensive review. So I think we will have a Q&A at the end of these sections. So I would like to hand over the microphone to Professor Yokosuka to introduce the next 2 speakers.
Okay, next speaker is Professor Wei Lai. Is Wei here? No. Maybe. Okay. Maybe next speaker is Ninkin, and she's. I will introduce Kin Nin, and she is anyway. She is an awardee of an Great Mentor Award of this year. She is working in Wuhan, and sorry,
it's on the screen.
Well,
Professor
about
Ikasuko, it's on the screen.
we may skip and then yeah. Is working in National Medical Center for Major Public Health Event and the Clinical Study Center for Viral Hepatitis Hubei Province. And she's going to talk about the functional cure of CHB and real world. And please start, Dr. Kunin.
Thank you. Thank you very much, Professor Ikasuko. Dear Chairman, Professor Kao, ladies and gentlemen, good afternoon. So I was assigned to talk about the real world of functional cure. Here is my outlines. So I would start with from randomized control trials to real world study and the real world. So actually we studied this study in about 2006. So we named it as Ocean Study. It covers several randomized controls, also real-world study. So it's named as OSET study, COST, Endeavor, and ANCHOR. So as you can see, it's the first letter of each study that symbols as ocean. And after all this completion of the study, we have enrolled them for a long-term follow-up. So which means from the RCT to the real world. So today I'm going to share some of the results with you. The ocean study, the first ocean study named OSET was published in 2014 in Journal of Hepatology, which was a very simple design. One is the standardized entecavir treatment. Another group is switched to pegylated interferon, which give us 8.5% of the S engine loss at the end of treatment, 48 weeks. Then we went on to the Endeavor study, which has 3 groups. The control group, just nuke, and then sequential to interferon. And the triple group, including the interferons plus interleukin-2, and also therapeutic vaccine. So as you can see, it revealed as 9.4% of the S antigen loss in the triple group. However, if we only including the patients with the S antigen greater than 100 IU per ml and less than 1500 IU per ml, then we have about 20% of the S antigen loss rate at the week of 48. Then we went on to the ANCHOR study, which was recently published in Journal of Hepatology, which has also 3 groups, with the second group in combination with pegylated interferon and extension of the interferon therapy to 96 weeks. And the third group, in addition to entecavir and the pegylated interferon, we have GM-CSF for the first 48 weeks. Then we achieved 26% of the S antigen loss plus nearly 25% or yes, I think it's over 25% of the patients achieved S antibody. So in 2015, we were invited to give a letter that talking about the thoughts of for functional cure. And we think the integration of deeper viral suppression with sequential immune modulation to restore antiviral capacity, which could be the future of chronic hepatitis B patients. And based on these studies, as well as many reports from other scientists and clinicians, we had this roadmap for functional cure of chronic hepatitis B, which is an expert consensus published in 2019 in Journal of Viral Hepatitis. Basically, we have two evaluations, either at baseline, that if the patient has S antigen less than 1500 IU per ml, which we highly recommended to sequential or add-on pegylated interferon at week 12 or 20 weeks or 24 weeks. Then if the patient's S antigen less than 200 IU per ml, then we highly recommend it to continue the pegylated interferon therapy. At week of 48 to 96 weeks, that for those patients who still has S antigen positive, then you probably need to stop the immune modulation representative by pegylated interferon and continue DNAs. And for S antigen loss or seroconverted patients, we highly recommend it that you can stop both. So these results has been validated and also has been carried on by other studies, such as the New Switch study, Pyramid study, Pegan study, and the Stronghold studies, which many of you are very familiar with. So how about the real-world results? Then we conducted the cost study. So this real-world study, I show you the interim results. It's a multicenter open-labeled study. The primary endpoint is the S loss at the end of treatment, which is 48 weeks. The secondary endpoint is the decline of S antigen levels and S antibody seroconversion. So we enroll patients with HBV DNA less than 500 copy per ml and qualitative S antigen less than 3000 IU per ml. And these patients will group to either nuke treatment or they have addition of pegylated interferon. And we have total 1,500 patients with the about 1,000 patients in the pegylated interferon group. And here is the study flowchart. And we screened 1605 patients and enrolled 1392 patients. And for those patients that we included for analysis is 1,196. Then we analyzed the results at baseline, week 12, 24, 36, 48, and followed up 24 weeks after the cessation of the treatment. So here is the baseline demographics and the baseline characteristics, which, as you can see, this is the real-world study. So we can notice that in terms of the age, there were differences in group 1 and group 2. The younger patients tend to receive addition of pegylated interferon, and the mean S antigen in the group 2 is a little bit lower than the nuke group, but it has significant differences. Other than that, all the other the parameters are comparable. So the combination of NA and pegylated interferon up to B led to higher rate of S antigen loss at week 12, 24, 36, 48, and followed 24 weeks after the cessation of the treatment. So the rate is 35% roughly. And you can see the combination led to more decline in S antigen levels from this figure. The side effects, the side profile is quite similar to previous reports based on the pegylated interferon therapy. The interim results of OCEAN study is also a multicenter open-label study, and the primary endpoint is sustained S antigen loss at the end of follow-up, and the second endpoint is the S antibody seroconversion. Now we have 170 chronic hepatitis patients who treated more than 1 year, and these patients are eligible for the combined with pegylated interferon therapy for as long as 96 weeks. And we have about 56 of patients and 114 patients either as negative or as positive for this study, and we have eventually up to now we have 79 patients were analyzed for the 96 weeks after the discontinuation of the treatment. So the sustained functional rate, cure rate at follow-up time after the discontinuation seems declined over the time. So at the end of 24 weeks of follow-up, it was 87.5%, and then after 1 to 2 years of the follow-up, it declined to like almost 42%. So there are several real-world studies conducted in China, and such as led by Professor Gao Ziliang and many other scientists and clinicians. So we have recently conducted a survey across China and part of the Asian Pacific regions, and we are very grateful that over 1,200 clinicians respond to our survey. I will show you these results. So this is how we did this, the national and international survey. We asked it about 10 questions, and here are the answers from 1,268 doctors, clinicians. So basically, the distribution of the severe response in China by provinces is shown in this figure. And over 60% of these clinicians were from the county grassroots hospitals, and over 30 of them from the provincial city hospitals. And we have the question for the recommendations to receive combination therapy with immunomodulator and nukes per year, and we have response that is 109,000 of over this recommendation patients, and among those, over 109 of these patients received the therapy, and end up we have 3,807 of these patients achieved functional cure. So by calculation, roughly the functional cure rate is 35.46%. We have several clinicians from overseas that joined us for this survey, and the response of the clinicians were 38, and the numbers of the patients recommended is 183, and among those, 17 of these patients achieved functional cure. So the functional cure rate is 22.97%. And we ask whether the clinicians use baseline guided treatment strategy. And as you can see, is well responded. Over 80% of these clinicians said yes, and only roughly 12% of our clinicians said no. And for the response guided treatment therapy, and over 90% of our clinicians said yes, and only less than 10% of our clinicians said no. So for the end of treatment, whether we need S antibody great, then whether our clinicians acknowledge it that S antibody greater than 100 IU per ml, or the CR antigen less than 1,000, that means 10 to the 4th log IUs per ml, which we named as HBV cure crop model, And we can see that over 70% of our clinicians said yes. Less than 30% of our clinicians said no. So we move on to see whether our clinicians have known that there is expert consensus published in Journal of Viral Hepatitis, and over 90% of our clinicians said yes, and less than 10 said no. So we like to ask whether our clinicians remember a little bit of history about the switch study, which is named OSET study, published in 2014 in Journal of Hepatology, which we think is the first randomized controlled trials to achieve clinic functional cure after sequential therapy in a durable course of the treatment, and which showing that 60% of these said no, and 35% of our colleagues said no. Then we moved on to the Endeavor study, and over 70% of our clinicians said yes, and less than 30% said no. So, which demonstrated the either sequential or add-on strategies with immune moderators such as interferon or IL-2 or other immune moderators was well known, and our doctors recommended our patients to receive this kind of strategies, and which yield very similar results with the randomized control trials. So last, I would like to show a little bit of these results from our randomized control trials, the pilot study we named as Ocean Cure 5 study with the novel regimens. So this is a randomized control open-labeled phase 2 trial. And the primary endpoint is the decline in S antigen quantification at end of treatment and end of follow-up. The secondary endpoint is the proportion of patients achieve S antigen less than 100 IU per ml, S loss, or E antibody seroconversion at the end of treatment and end of follow-up. But when we enroll our patients, actually we found we're most likely to enroll the E antigen negative patients. So the enrollment criteria is S antigen greater than 250 IU per ml, but less than 5,000 IU per ml, HBV DNA less than 20 IU per ml. And these patients were randomized into 3 groups. So the first group is only nuke monotherapy. The second is dual therapy, and the third one is the triple therapy. And the third one is in combination with TQA3334, which is a TOR7 agonist. And the last one, the triple, is addition of the TQB2450, which is a PD-Ligand-1 antibody. And the interim analysis of this study demonstrated that triple combination of nuke and TOR7 agonist and the PD-L1 monoclonal antibody, the triple therapy induced a greater and more durable S antigen decline in virally suppressed chronic hepatitis B patients, as demonstrated in these 2 figures. So, ladies and gentlemen, in summary, sequential or add-on therapy with nuke and pegylated interferon can enable about 30% of the virally suppressed chronic hepatitis B patients achieve functional cure from randomized control trials. Studies from the real world, including the COST and many others, and the national survey show very similar results as those from randomized control trials. This information may provide the assistance for the evaluation and the design for future studies with novel regimens in curing chronic hepatitis B patients. With that, I would like to acknowledge my colleagues in my department as well as the national study groups in China. Thank you very much for your kind attention. Thank you.
Thank you, Professor Kinnin, for your nice talk. Okay. And well, title talk is functional cure of CHB in real world. And although I cannot introduce well, but she is director of State Key Laboratory for zoonotic disease in China. And she graduated Tongji Medical College. And I told before she was awardee of Grant Mentor Award in this year. And next speaker is Professor Lai Wei, and then he is a graduate of Beijing Medical University, and he studied in Pennsylvania State University for a while and worked at the Peking University Hospital Institute as a director. And he's the director of Hepatopancreatic Center, Beijing Tsinghua Changhua Hospital State of Clinical Medicine, Changhua University. And he is the president-elect of Beijing 2025. Please start, Professor Wei Lai.
Thank you and good afternoon, and thank you and Professor Yokosuka, thanks for your and kind introduction, and thank you and the Professor and Chairman and Professor Yokosuka and Professor Gao. I'm so sorry I'm late. My talk overlaps, and here I will discuss something for surface antigen cell clearance, surface antigen loss when East meets West. Is my disclosure. So. Around 296 million people infected chronically with HBV virus in 2019, with an estimated 800,000 deaths each year after now, mostly from and died of the cirrhosis and hepatocellular carcinoma. So therefore, how about HBV infection and the cirrhosis and hepatocellular carcinoma? After all, antiviral treatment already reduced and delayed the fibrosis and program. So therefore, can slowly advance of the cirrhosis and particularly by 40 and fibrosis. And effective treatment and 5 years already show us take 5 years treatment, the cirrhosis even reversed in 74%. So already reduce the cases of liver cancer, improve the long-term survival. So therefore, in addition to HBV DNA and suppression, the surface antigen clearance is also associated with the improved clinical outcome. So therefore, surface antigen clearance is so important, at least in a current study and clinical practice. And however, spontaneous surface antigen clearance occurs at a very low rate. Around the annual rate is of the 1%, even lower. So, how about the treatment? After all, an already approved treatment has two kinds of the strategy. The one is the pegylated interferon, and the second is the nucleotide and the nucleoside analogs. So if you look at the data from the two kinds of the treated population, the first one is the pegylated interferon, and usually it takes 48 to 52 weeks of treatment. Also, you also see some in the study and the duration and lasts for 3 years. And also, the nuclear analog treatment already proved for a long time. So therefore, we also can see some in the long-term treatment data, up to 7 years, even 10 years. So look at the data that you can find. In the E antigen positive populations, and the 6 months treatment for and after the treatment, after stopping treatment, and 6 months, the E antigen population, surface antigen and clearance maybe achieved 3% to 7%. And if we take longer follow-up and up to 3 years post therapy, the E antigen positive patients, maybe surface antigen and increased to 11%. And however, if we look in the E antigen negative populations, it's pretty similar, and with the E antigen positive populations, maybe a little bit low, a little bit high, and for surface antigen clearance. And meanwhile, if you look at the entecavir, TDF, TAF, this is the first line treatment, then you can find even to 10 years and 5 years, the surface antigen clearance is pretty low. So therefore, how to do? Firstly, is the surface antigen loss testing. And up to now, and we already used a very sensitive and the AC for that. And even compile and the different and the commercial kits is also and consistent between that. So, but you have taken into consideration, and that is we have to use the and sensitive kits. So therefore, the cutoff for surface antigen loss definition is the 0.05 unit per ml. So therefore, take this and the criteria, you can compare some of the study. The first one is, and if we stop nukes, how about surface antigen clearance in Asia or in white and in Caucasian populations? Here is the study, and for the E antigen negative and no cirrhotic patients. In this study, in Asia, the 45 patients stopped nucleotide and the 22 continued treatment. And after the nukes discontinuation in this population, in the 45 patients, only one cases and achieving the surface antigen loss. So therefore, it's pretty low in this kind of patients. Stop nucleotide, and it seems no benefit on surface antigen clearance in Asia. Then, so how about in Caucasian in white? And I pick up two studies, both for E antigen negative population without the cirrhosis. In this study, and they have the 83 patients stop treatment, 83 patients continue Leukocyte treatment, and the taste after surface antigen after the treatment discontinuation. And then you can find the surface antigen loss in the stop is achieved in the 10%. But of course, you have to note the sample size is not very big. In our study, the results is pretty similar. Also in the less and the sample size, and 21 stop treatment and 21 continue. And the timing after Leukocyte discontinuation is the 144 weeks, even longer. Then you can find in this stop and the treatment 21 patients, there have the 4 cases achieving the surface antigen loss. And totally the percentage is 19%. So therefore, it seems that if we stop nuclear analog treatment, it may be and have the higher surface antigen, maybe have some benefit for surface antigen clearance. So therefore, you can find these differences between the Asia East and the West. We just mentioned for the stop nuclear treatment on long-term surface antigen loss. So therefore, what time, what about the surface antigen and the quantitative and has any impact on the long-term and the surface antigen loss? You also can take some an example here, and you can find in all these Asian study, and the end of treatment, the surface antigen quantitative less than 100 IU per ml is associated with the surface antigen loss in Asia. Then you can find here, and so it seems, and no than 100 IU per ml in Asian populations surface antigen, and may be associated with the surface antigen loss. And however, if we look at the Caucasian, the white population, and here is the 2 study. One study is the end of treatment surface antigen quantitative less than 1,000 IU per ml, and other is the 100 to 1,000 IU per ml. Then you can find in this kind of populations also have the surface antigen loss. Of course, the sample size is pretty low. So therefore, it seems maybe the end of treatment quantitative surface antigen and a different level in Caucasian or in Asian with the surface antigen loss. So therefore, in Asian populations, if you want to achieve the surface antigen loss after leukocyte stop treatment, so please be careful. And so the patient's end of treatment, the stopping time should have confirmed surface antigen and less than 100 IU per ml. So actually, and currently, and you only have approved drug, that is the Lux and autopharon. So therefore, if we can use a different strategy, combine or add on or a sequential packet interferon and Nukes to increase the surface antigen loss. So what is the select the population if we use this strategy? And here is the study conducted in China. Then you can find the PEG interferon alpha induced surface loss in nukes in the treatment experiment and the populations. The definition for nukes in treatment experiment defined as the use nukes longer and then 1 year. Meanwhile, when at the baseline, we enrolled HBDNA less than 100 IU per ml and E antigen negative, surface antigen less or equal and 1,500 IU per ml. Please take this. Maybe I mention it in later. And also, is the packet interferon add-on, the Lux and going on. The treatment duration is 48 weeks to 96 weeks treatment. Or, of course, is dependent on the patient's compliance, also the surface antigen and dynamic and decreasing. Then you can find here, totally in the ITT analysis is the more than 5,000 and PP and less in 3,000. You can find up to in the 48 weeks, and you can achieve the 33.2% of patients achieve the surface antigen and loss. So therefore, it seems implied if we selected Nucleus treatment patients going on treatment with less load, viral load, E antigen negative, and also the surface antigen less than 1,500, maybe and I can achieve and 1/3 patients obtained surface antigen loss. In addition, this very huge sample size study, there are, and we also have some other studies in different areas, in different cities, including in Beijing and northern China, and Xi'an and western China, and also the Xiangya, central of China, and Henan, or central China. In this study, they have the different and the duration for treatment. Then you can find the surface antigen cell clearance still can high and this a kind of HB as HB carrier. So then if you look at the patients the biomarker, then you can find the baseline surface antigen is pretty low, and also in these different populations, most of them and less than 50 IU, 20 IU, or maybe 100 IU. So therefore, and for this kind of patients, and if you want to achieve the surface antigen, even in the surface antigen carrier and use the packet interferon and a little bit longer duration, maybe achieve the surface antigen loss. So we also some other pilot study, and you can find the packet interferon induced surface loss in active surface antigen clearance carrier. This study was conducted in the central China and Henan province. In this study, you can find the prospective and the randomized and the 40 inactive surface antigen carriers, and totally and they randomized the two and the groups that actually you can find the two groups is comparable, including the surface antigen load and the surface antigen and the level and the HBV DNA viral load, and also the ALT and the level, also for the and age and sex. Then the treatment, they have the two strategies. The first one is the group 1. They use the PEG interferon and treatment and up to 68 weeks. Then 8 group, they have the 2 cycle for PEG interferon and treat, and also is the needing in the period of the GM-CSF and the vaccine. And then the primary endpoint was the surface enlarged lot. Then you can find in group A and group B, the profile and for fast analysis is pretty similar for the surface antigen and clearance and loss. So, and the another study in the look at for PEG interferon retreatment on PEG interferon treatment failure previously, and totally they enrolled in the 92 cases. The baseline is surface antigen less than 1500 IU per ml, and the E antigen negative and HBDN undetectable. The cutoff is the 20 copy. I don't know why they use a copy, and the Nukes treatment and more than 1 year. And they have the 2 groups. One group used the PEG interferon and 48 weeks, and other one is also use the same one. And it's one treatment experience and the treatment and life is the differences. Finally, it could be found the surface antigen loss and the surface antigen cell conversion, and in respect, yes, 29 or 22 at week and 48. Of course, if you look at the in 2 groups, one in treatment experience, other in treatment life, the surface antigen cell clearance achieved in 34% and 26%. It seems, and for this kind of treatment of experiment patients, you can retreat the patients by the PEG interferon if the patient want to achieve the surface antigen loss and the clearance. So, and finally, our study is the interferon and PEG interferon induced surface antigen in the low viral load population. This is a single study and 240 E antigen negative patients and with the low viral load. And then you can find the PEG interferon combined Lukes and the Lukes and plus Lukes in the 48 weeks. Then you can find in these Lukes plus Lukes arms, the surface antigen and loss is lower. And however, in this kind of population, in this group, the PEG interferon combined Lukes treatment, the surface antigen achieved to 30% in is the low viral populations. So, and today, and we come to the function Q and the error. So how about the surface antigen and loss or reduction, and the difference between the West and the East? And so we take an example. That is the BEPI reversion. It's the only, and it goes quickly in a clinical trial and new drugs. And then in this medicine, the randomized and treatment experience and treatment life and the patients, the bepirovirsen used and the 150 and 300 and milligram, and also placebo. Treat is the and the 12 to 24 weeks, then follow up and 24 weeks. And then you can find in different and the genotyping. I actually in the paper, the baseline characteristic, they show us the Asian, white, and the black. And however, in the paper, as well as the supplementary, we cannot find the data for the subgroup analysis for all Asian, Caucasian, and Black. They only have the genotyping, but the Euro and the genotyping B and C, and most of prevalence in Asian, and A and D in European. And so therefore, we just took a comparison between these genotypings. And however, then you can find among the different genotyping A, genotyping B, genotyping C, and genotyping C, even the genotyping E, then you can find in these treatment-naive populations, the surface energy reduction is pretty similar. And meanwhile, in addition to the treatment-naive, look at the treatment experiment patients, then you can find even the B or C and the surface energy reduction is more significant compared to other genotypings. And also, it is in this poster, it also said the surface energy clearance and 12 weeks after BP was stopped, and also is stable for doing the follow-up. So, ladies and gentlemen, and I conclude here, surface energy loss and undetected and HB DNA after 6 months after entire viral treatment is defined as the function cure. And the function cure is associated with improved clinical outcome, and it's the optimal goal of the therapy for chronic hepatitis B. Surface antigen clearance rate is different between the East and the West, both on treatment and after treatment. High end of treatment quantitative surface antigen as associated with the surface antigen after stopping a nucleotides. And the new function cure agents achieving similar surface antigen cell clearance and the reduction among different HBV genotyping. Thank you. Welcome to APASO 2025, the Beijing. I look forward to seeing you next March. Thank you.
Well, thank you, Professor Weilai. And as we have discussed, Professor Nakamoto Yasunari, and he will have some comments to the speakers and also questions if we have. Please.
I think all the speakers are invited to the
Yeah,
stage. Yeah.
You could do this.
Okay. So, regarding the Professor Otsuka's presentation, so he presented the effect of the nitazoxanide study. And that agent is usually he exposed to use the add-on of the nucleotide analog. So and that NTZ suppress HBV transcription and also cccDNA. So that effect is the effect. Can you see the effect with a nucleotide analog? But is there an effect without nucleotide analog? Have you seen?
Yeah, thank you for your question. Basically, we observed in vitro studies first. So when we examined in vitro, we used only nitazoxanide. And only nitazoxanide only also suppressed viral RNA transcription. So, but in clinical trial, we are using nucleoside and nitazoxanide in combination therapy, as combination therapy. So I don't know, in the clinical, nitazoxanide only can suppress HBs antigen and HBs RNA, HBV RNA. So that is a future question. Thank you.
And also, you use this NTZ for HBe antigen negative chronic hepatitis B. So is there a difference or effect or mechanism is different for HBe antigen and positive and the negative patient?
Probably, I'm not sure, but probably there's no difference in terms of the mechanisms. But clinically, we think antigen negative patients is more, so it's more necessary to examine antigen negative patients. So we chose the antigen negative patients.
Thank you very much. I think it's very hopeful development. So that is question for him.
Well, we can accept the first, question.
Please identify yourself and ask questions.
This is Chunfeng from Gilead. I have few questions. The first one is related to the safety. Thank you so much for the very comprehensive data. So the safety questions for, let's see, for the NTZ molecule and also the safety are related to the use of the interferon alpha and also the PD-1 antibody. Could you give us some comments?
About the first one, safety, nitazoxanide is a very safe drug because this is approved by FDA for some pathogens in children. So they use for children. So I think this is a very safe drug. And second one, I'm not sure the combination therapy. I have never done because so we will examine in the future. Thank you very much.
Before Dr. Yeah.
So I'll go first, and then Professor Wei Lai will, add on more information. In terms of the safety of pegylated interferon, I think it's well known. Everybody knows it has, a little bit, the side effects that clinicians probably would expect that will be mild, because as you know, that extension of pegylated interferon can induce higher S antigen loss, but in fact, that's not the case. So I think that's very important to explore the new immunomodulators. In terms of the safety of the PD-L1 monoclonal antibody, so in this phase 2 clinic trial, actually, one of the important things is to see whether two immunomodulators, like 7 agonist, in combination with PD-L1 antibody would be safe enough to explore. So luckily that the safety profile is quite satisfactory. I did not show the detailed results, but most of the side effects, the SAEs, grade 1 and grade 2, and none of them are grade 3. And after cessation of the treatment, the side effects were gone. Most of the side effects were only thyroiditis. Yeah, thank you for your question.
Thank you.
And actually, if you look at the in cancer treatment, PD-1, PD-L1, then you can find the PD-1 safety issues is higher compared with the PD-L1. So therefore, if you do that study, I would prefer to use the PD-L1 first to try that. And also, very few in the study for that. And a few of years ago, Professor Edigan from New Zealand, published in the first study in the Journal of Hepatology. It seems that only in the 11 people. Anyway, the safety seems tolerant. But you need more data for that.
Okay, I have another question. So related to the mechanism of the interferon alpha, after you use, so what's the potential mechanism? Does that also applicable to, let's say, combination treatment? Let's say use the SRN first and then plus interferon alpha. Thanks.
I think this is a great question. But until we perform experiments, I mean clinical trials, we have no answer for that. Based on the studies from our group, we have explored the mechanisms of pegylated interferon in CHB patients. In addition to its mild direct antiviral effects, it's been well demonstrated it has multiple immune modulation effects. So to our understanding that we have measured those immune responses in parallel with our, clinical trials. So what we observed is we've seen for those with steadily S antigen decline patients, they have a good profile of restoration of their innate immune response as well as adaptive immune response, which has been published in various of literatures. Briefly is the NK cells molecule expression, the regulatory T cells decreasing, and their functions decreasing, and also we've seen that the B cells expression of the activation of the B cells as well, and the TFH cells. So there are other studies from Chinese group and many others from Asia. I think it's been a lot of evidences for that. Also, I remember one of our studies showing that the microsomes induced by interferon in the hepatocytes, which can transfer that to the immune cells and exhibited that the immune modulation effects. Yeah, I mean, in details, you may need to go back to the literature. Thank you.
Okay. Wait. Okay, go ahead.
Okay, thank you. In terms of the immune stimulator, and besides for the interferon gamma or interferon, what do you think of other types of immune stimulators, especially for the therapeutic vaccines?
Yeah, thanks for the question. I think this is a very important question because, in fact, we have not found a safe and potent immune modulators which can be the partner of other DAAs in HBV infection. So my answer to that is we need to make good use of pegylated interferon. In addition to its side effects, it's lots of good things. So the thing is, we need to, sort of manipulate what or how we will use this good drug. In addition to that, I would say, the PD-1 ligand pathway, I would say is quite important for restoration of the HPV specific T cells response. So that's one of important thing. And the TOR7 and TOR8, especially TOR7 by itself seems not promising, but we do not know that if we combine TOR7 with other immune modulators in the adaptive immune response, would that yield unexpected results, which is a question. We are now conducting the experiments. I think we will have some of the answers for you in next 1 or less than 1 years. Yeah, that's how much I know. Would you like to?
As Professor Nakamoto is an expert of the immunological aspect of HBV infection. Could you please have any comments about the immunological mechanisms for functional cure?
Thank you very much. No, I feel the study results are very nice, and the checkpoint immune checkpoint inhibitor works very well, right? I think it's surprising for me, but probably the the characteristics of the patient different from country to country. So probably in Japan, the more aged patients are mainly involved in that treatment, and in your country, the ages are probably younger than 60 or that in that enrolls patients. So that may be, limitation of the PD-1 or that kind of, I think. But my question, I have a question more that study. Is that okay? My question is, probably you have the HBS antigen loss patient, but also the reactivation patient after cessation of the treatment. Do you have a you don't? Or I'm interested in the difference of reactivation with or without checkpoint inhibitor treatment.
Yeah, that's a good question. So we are talking about two things. Number one is the reactivation of the immune response during the treatment. Number two is after the cessation of the treatment, whether there is a reactivation of the immune response, right? Or by various reasons. So yeah, the first one is there is slightly ALT flare. We can only say that this is probably one of the markers for the activation of immune response until we have better markers, but not that much. So it's only slightly. So during the whole course, it's quite safe. So there's none of these patients that flare to a severe hepatitis. None of them. Yeah. After cessation, we do not see the flare of any of these patients during the follow-up. However, I don't know whether you only ask it for these new regimens, or you want to understand, or you want to ask about pegylated as well.
Yes, I mean, you said the new drug agents are safe, but probably under the treatment of the nucleotide analog. And after the cessation of these drugs, or including nucleotide analog.
So are we talking about the combination with TOR7, or you're talking about the pegylated interferon? I'm sorry.
You treated patient with a nucleotide analog and two immunomodulatory agents, and in the final.
Yes.
And
so
after that study,
the ANCHOR study.
The final one, and that
the final one is the Cure5, right?
Yes,
the Cure5. Yeah.
So in that study, the cessation of the treatment means this is just immunological drug, or
there is a combination with the nuke triple
also.
Yeah. 3. Yeah, so we have one group only nuke, second dual, and the third is the triple. Yeah.
And
if you look at the ASLD's abstract, there's a little bit more detailed information over there. Yeah.
Maybe I can have some comments about the immune
Thank you.
mechanism of HBV infections. As we know, the HBV disease is mainly immune mediated. So the immune function is a two-edged sword. On one way, it will control the viral infection, but on the other hand, it will cause the liver cell damage. So if you want to have a functional HBV cure, of course, there are several immune enhancers, like we just discussed, including the interferon alpha and also the anti-PD-1, PD-L1, therapeutic vaccines, and the toll-like receptor agonist. But except for interferon alpha, The other agents are now under clinical investigation, for example, on the clinical trial. And as I know, the cerebrosine alone may not be so effective. So some companies, they are doing the combinations. But I think the most important question is when and how to combine these immune enhancers on top of the already existing drugs, for example, the nukes. And of course, there are some other antiviral agents that including the siRNA, for example, the GSK ASO, and also CAM inhibitors, the capsid inhibitors we call the CAM. So what kind, now there are a lot of maybe new agents. So we need a very huge clinical trial with different arms, with different combinations. And finally, we can find the solution to reach the functional cure. So that's my opinions right now after reviewing all the literature about the HBV infection. But I think the host immunity is still very important if you want to control the HBV, especially to clear the HBsAg. In fact, I have several general questions to the speakers because it's very difficult to have these experts in one sections. So after hearing all these presentations, I think either the traditional interferon alpha with a new combination or with some new drugs, the ceiling of HBs antigen loss seems to be 30%. So are you satisfied with the 30% SAG loss as our standard of functional cure? This is the first question. Maybe Professor Ozuka can answer first.
Yeah, of course, not satisfactory.
So what's your standard?
Yeah. But comparing the current nucleoside therapy, 30% is already higher than the nucleoside analog. So currently, at the present, it is okay. So not satisfactory, but I think it's okay.
Oh, Professor Wei.
And at this stage, 30% is good. And if some new drug can achieve and so pass 30%, then you can consider the next step. And however, actually, and the Professor Gao mentioned in the 30%, actually even maybe 25. I think it's not very easy for that.
Mm-hmm.
So the question is, and the how to use that. You also mentioned for the some compilation, and the up to law and the different and the compilation. The lot of and the very and the promised the outcome. So it's energy loss.
Mm-hmm.
So only one is just bepirovirsen. So therefore, and I think and the in future and the you need to do more clinical trials. And in the a few of years ago, and I don't know why, in the recent years, in the or is this the new compound combined with the nucleus and the so-called virologically suppressed population. Then, however, a few years ago, you know, the bluebotide already approved the condition for hepatitis D treatment. And previously, and this drug also have the clinical trial for chronic hepatitis B infection.
Mm-hmm.
In that clinical trial, they used the PEG interferon as a basement treatment.
Mm-hmm.
So after that, very few. I did not see many for PEG interferon. So that's the reason that I talk something for the PEG interferon. So if possible, and for some other study, because the interferon is currently in up to law only and approved in immunostimulation some mechanism inside.
Mm-hmm.
So therefore, maybe use this one combined. I'm not sure with CPAM, some siRNA. I'm not sure.
Mm-hmm.
that combine something. Maybe I'm not sure. But anyway, 30% I think is good. But maybe it's just imagine it's not easy to achieve for that.
Yeah, but I think we should aim high, right? There's a Chinese saying, 举法乎上，得乎其中.
Yeah.
What do you mean?
We can aim high, but we can get a median results.
I see.
Do I need
Professor
to say
Ning.
more? Professor Wei Lai is very easy to go man. So 30%, he's very satisfied. But I think everybody in this room probably not satisfied with 30%. Although it's better than nothing, I think. It's like comparing to about 15 years ago. We do not have a rule or even, so I think these 30% shed lights on, our future for CHB patients. However, we do need to work harder, aim high. I would think that 80% will be acceptable for me in the next 5 to 10 years. And of course, it's a long way to go according to the recent, evidences. So we have lots to do. Yeah, thank you.
Yeah, I think for patient, the higher the better, right? For patient.
Yes.
So, but I need to raise attention that actually the 30% of SN loss is focused on very selective populations. Usually the S antigen may be less than 3,000 or less than 1,500. 100 IU. Yeah, so it's the S antigen not very high, so it's a selective population. So we use the nukes or interferon, we can have a higher chance of S antigen loss. So I think Professor Wei also mentioned about we call the stop to cure. That we discontinue the nukes and we can have some loss of surface antigen. Of course, it's different between the Western people and Eastern people. And from the retrospective study for Western patients, after 4 years of follow-up after stopping the nukes, around 40% will have S antigen loss, but for Asian patients, only 30%, especially for those with surface antigen less than 100 at the end of nuke treatment. So if we want to apply this strategy by stopping the drugs, what kind of consideration we should have after stopping the drugs?
Actually, not very not much many well-designed study. So this study and always the patients, if you look at the data, the patients and they take the drug, take nukes for a long time. So therefore, I think and currently what do you think? What we can do is the treatment of patients longer. So therefore, you have the more opportunity. I just mentioned an interferon combined with some function Q agents. But actually, if you look at this function clinical trial, then you can find in most of the study, the patients, so-called virological suppressor, I mentioned, will have the high chance compared with the de novo compilation. So therefore, I think what you can do currently just treatment of longer.
Mm-hmm. Okay, thank you. Because we have practitioners in the audience, I need to alert that if you stop the nukes, actually from the previous literature review and the prospect study, around 50% or 70% will have the surge of HBV DNA, and some of them may have hepatitis flare, and the 1 to 3% may develop hepatic decompensation and even failure. So if you want to apply this strategy to your patients. So please have a very close follow-up of this patient. And of course, you can refer to the Apostle guidance about the stopping drugs. I think myself and Professor Ning, we are the authors. Yeah, so please look at that, and we can have a very strict follow-up to avoid such a disastrous event to develop. And I also, I recently read a paper by Professor Fusen Wang. They published a paper for young patients, for example, the pediatrics. So they use interferon, as I know, and it seemed to have even higher S antigen loss rate. So does it suggest that we should treat the patients as early as possible? So what are your opinions?
Um, it's very hard to to comment because I'm not a pediatrician, and I mean those data are quite promising and demonstrated that great results with the young children. However, my concern is the side effects of pegylated interferon and whether there is any information on their, growth of their childhood or even teenagers. So, I mean, I do not see patients like pediatric patients. So I think this the significance of this study is not just for the treating of pediatric patients, but also probably implying that we may need to treat our young adults, we call that, as early as possible to have the better chances for functional cure. I think that's the point that I would explain. So other than that, I think it's quite encouraging for us. Yeah, thank you.
Okay, thank you for your comment.
In
So
Beijing, and we discussed the data a few
Yeah.
of times, and the different people have the different thoughts. 仁者见仁，智者见智。You can say Chinese.
Right.
So and anyway, and some you still have some consensus.
Yes.
And the consensus is in the data is very good. And also, and the safety profile is good. If you look at the data, it seems that and the safety profile is good and is better than adults and the patients that received in the pegylated. And also the surface antigen loss is high for these populations. And also, we also mentioned if we give the charging the treatment, and you still can have the other drugs such as the Lukes. They still have some the low dose for charging.
Yeah.
And so it's a consensus. And meanwhile, we also discuss what age is good for treatment.
Right.
So and some bodies think age is less than 1 year is fine, but most of people think it's maybe 3 years or something like that. So I'm not. I just introduce what we discussed.
Right. Thank you. Thank you. Very precious comments.
How
I
about
think, sorry.
how about Otsuka, Professor Otsuka?
Sorry, I have no comments about that, but instead, I want to ask Dr. Yokosuka. Honestly, I have never used combination therapy or or sequential therapy of PEG interferon to nucleoside analogs. And I believe most Japanese doctors do not use such a sequential therapy or add-on therapy. Why there are the differences?
Trial by the doctors in near Kobe, and the result is better than only nuke therapy. And so there are some trials, but not so much because maybe an interferon has some troublesome problem, and nuke is and have almost no complications. So maybe we only use nukes and not to avoid complication.
So,
I think.
but looking at the data today, we may we need to introduce more PEG interferon on nucleoside analog.
And I think nuke only have a very low level of functional cure, and you need interferon or such immunomodulating drugs. But still, as Professor Kao said, there's a limitation of the rate of functional cure by only interferon or some immunomodulators. But we need more strong and immunomodulating, but no complication drugs. Those drugs should be explored, I think.
Yeah, I think that depends on what is our endpoint. If our long-term outcome, we want to reduction of liver cirrhosis, SCC, and liver-related mortality, I think the long-term nuke therapy is good enough. But if we want to have some finite therapy to reach HBs antigen loss or functional cure, maybe the immune enhancer can help some of our patients. And I think the next year in Beijing, in Professor Wei's meeting, we will have much more data about how to reach HBV cure on our journey.
Thank you. You have many data.
Oh, thank you so much. So finally, I would like to invite Professor Yokosuka to give the closing remarks.
No. What I said last is my closing remarks, and I'd like to thank all the speakers and commentators. Thanks very much, and also participants in this session. Thank you very much.
Very good. I'm sorry. Thank you.
Thank you very much, the lecturers and moderators.